I'm going to be leading this parallel session called Health versus Social Care, Differences in Context and Methods. And I'll be just talking about my own personal experiences. I'm not an expert in the Research for Social Care program, and I'll be kind of drawing on some of my own kind of personal experiences of working within social care research. So just to provide a bit of a background to the work that I've been doing. My research interests are in the geographies of disability and social care. And given my background in geography, I'm particularly interested in the way in which social care as a landscape, as a carescape, really looks. Basically, where care takes place, what are the types of organizations involved, really getting a sense of mapping out the types of supports and provision that's out there, and really getting a sense of the differences across different regions and local areas. I should also say that I'm a qualitative researcher, so that might help give you a bit of a flavor of the types of methodologies that I've used, because I think if you've joined us for the whole of this morning, you'll have heard from some of the other speakers who've talked a bit more about the quantitative work that they've done. I should also say I've served as the chair of the Geographies of Health and Wellbeing Research Group, which is part of the Royal Geographical Society. So essentially all the health geographers, both within the UK and internationally. So that has given me a kind of a wider range of interests within the health and care field. There are three kind of key projects that I've been very much involved with. The first one, Active Citizenship and Disability Project, was very much looking at self-directed support. Although I was based in Ireland at that time, it was an international study where we looked at the UK, Ireland, in comparison with the US, Canada, really getting a sense of how self-directed support was evolving in those different jurisdictions. More recently, I led as a PI an ESRC funded study looking at how adults with learning disabilities and their supporters, their allies, local friends, their peers, their advocates, were really helping to self-build lives in the community. Okay, so that just finished in March of this year, and you can have a look at that. And finally, I've recently got funding through the NIHR, the School for Social Care Research, looking at the group home sector, so residential care homes for people with learning or intellectual disabilities, and really trying to help those working in the sector, trying to promote more home-like environments for the residents in those settings. So that just gives you a little background. I've been asked to just talk a bit more about the context, really framing social care. And if you joined us this morning from Martin's talk, he provided some really helpful context as well. So I would urge you to look back at that. There are two key overarching pillars that really have, if I was to distill what the key overarching principles within social care have evolved to be. So personalization is one of them, and co-production is another that's really become more pronounced. And if you compare that to healthcare, very similar type of pillars exist. So the NHS 5-year forward view, for example, really tried to champion co-production and really trying to advocate that support providers really try and tap into those community resources that are there. If I was to kind of go even further upstream, I would say that prevention, that preventative type of support really kind of frames both of those, that the co-production really feeds into that preventative agenda. The key kind of legislative developments, I mean, personalisation really first came on the scene with the Community Care Direct Payments Act, where a group of adults with primarily physical disabilities really tried to articulate that claim towards having control and choice over their personal assistance budget. In Control is an organisation that really began to recognise that for people with learning disabilities, there needed to be some kind of support mechanism for people to use their social care budget in a more personalised way. In 2003, there was the Fair Access to Care Services, which at that time was really designed more as a general eligibility criteria. But since then has really kind of evolved into a way that local authorities have really tightened eligibility criteria. And I'll speak a bit more about that in a moment. The Putting People First report was very much a kind of a landmark protocol for both health and social care, really kind of emphasizing that we need to really invest more in kind of putting people first, through self-directed support. The Ibsen review was a large national review looking at the use of individual budgets. And at that time, if you look at the time scale of 2008 and what was happening at that time, they noted in their report that there was really a tightening of eligibility criteria from that point. And the CARE Act has really kind of helped cement those key pillars and really kind of emphasize that preventative type of support. Alongside the national legislation, there have been a range of different publications that have really served to help, really provide guidance for local authorities. And we can see here there's a real strong commitment towards asset-based commissioning, really trying to recognize and support the assets that are available in local authority areas. And that includes everything from local libraries, local community groups. And you can see the types of organizations there that are really kind of championing that SKY, ADAS, LGA, Skills for Care. So, you've got a whole kind of range of different stakeholders that are really important for thinking about in terms of who the key stakeholders would be for your social care research. Of course, if I'm very much a visual learner, and I think this slide really just helps emphasize that the aspirations for social care that previously, a social care user would typically occupy the red box in a very kind of static, formal type of service arrangement. And the aspiration is that, the world is your oyster, really try and tap into what's there in the community with your support circle. But of course, the landscape of care services is still dominated by a very long legacy of congregated care provision. So a substantial amount of social care is still provided within the hospital and residential care services. And the previous project I mentioned, the Self-Building Our Lives project, the commissioners that we interviewed were very kind of aware that there's this great preventative work going on, but most of their energy was and their funding was really tied up in this sort of more formal statutory provision. And of course, there have been some various attempts over the years with the Transforming Care strategy, with a number of subsequent reports to try and kind of drive momentum with that agenda. So Martin kind of talked briefly about the way in which the landscape of social care is kind of beautifully opaque or kind of difficult to navigate. I mean, it is very fragmented. And it's fragmented in 3 different ways. So geographically, of course, the role for local authorities as the main commissioners for social care. So by the very nature of local authority provision, we've got very, very different types of relationships with providers. Some have very kind of have been tied to kind of institutional legacies, and a lot of the funding being tied up in those. Where in other areas they haven't really inherited that landscape, and have been really much more free to really kind of experiment and innovate. And of course, the local authorities aren't the only commissioners. So the CCGs have still a key role within that care landscape, particularly with more residential homes and nursing homes. So that's geographically. One key comparison or point of contrast, I should say, with healthcare is within the NHS, only about 11% of NHS kind of healthcare provision has been outsourced to the independent sector. Compare that with adult social care, and I mean, this figure could be out of date. This was a figure from 2013, so it could be much kind of higher than this. But at that time, the figure I found was that 90% of this is outsourced. And within that sector, then you've got private care organisations, not-for-profit, and the charity voluntary sector. And I was particularly interested in my my previous project looking at this sector, because although the policy aspirations have really tried to emphasise that we need to tap into these local community organisations, local authorities, it's almost it's often not being picked up on their radar. It has a lot of self-funders. There is a lot of micro-enterprises. So Catherine Needham's work has been really helpful for getting a sense of the types of organizations that are involved. And of course, that makes it really challenging then for recruitment and really tapping into that landscape. And finally, in terms of how this landscape is fragmented, it's also fragmented legally. So if you look at social care in terms of the range of practices that are typically carried out, they are themselves kind of divided up, almost like salami sliced through the legislation, that some types of roles may fall under a statutory duty where others don't. Okay, so just to provide one example of that, advocacy is now a statutory duty of local authorities under the CARE Act. And that's kind of one example of where local authorities have had to provide funding and commission. But of course, some of the organizations that I've researched, they had provided more than just advocacy. They had provided a whole range of different types of support. And some organizations have had to kind of cut all those other types of support and really kind of drill down to that core advocacy provision. Okay. And of course, some forms of care also fall outside of statutory provision. I mentioned the fair access to care services, the FACS, before, and increasingly more and more disabled people are falling in between. So they're not reaching that threshold for eligibility, but they're not readily able to move into work and gain independence. So it's a kind of a double discriminatory or disadvantaged place that many people are occupying. And finally, within the context part of my presentation, the adult day support landscape is also very much changing. This is an image from a local newspaper that I found that there was a closure of a day centre. But of course, this is happening all across the country. So in every local authority, there's increasingly less types of support being provided in these sort of designated or specialist type of day services. So the way in which people find support is often much more bespoke and ad hoc, where they might go to different places during the week. And that very much helped frame some of the research that I've been involved with. So I'm going to switch over now and just share some of my reflections and drawing on my previous projects. In terms of methodology, public involvement, so although PPI has a long tradition in health research, participatory and inclusive methods have also been around for some time in social care research. So Jan Walmsley and Kelly Johnson in 2008 published a book that was very influential, and it very much focused on how can we try and provide more inclusive and participatory methods with people with learning disabilities. So these approaches have different lineages, and partly this has been in response to the types of populations being studied. Okay, so people with social care needs, they may have particular learning difficulties, they may have dementia or mental health issues. So rather than the PPI within a health care setting, you may not, you might be working with a constituency who find it more difficult to engage, to seek consent from these groups. And this has really helped frame, my thinking and how I do public involvement. I should also say that social care users can also be very disempowered. Okay, so by the nature of their social care need, they might be more financially vulnerable. They might experience discrimination in their life. So this is very important for how you think about the relationship between you as a researcher and the ways in which you really engage and try to provide more of an emancipatory approach in the work you're doing. Some other kind of key sources really within inclusive research would be Melanie Nine's work. So she published it was a National Center for Research Methods report with Vinha in 2011, looking at inclusive research and how can you do it well. And of course, this typically involves closely working with a select group of people with lived experiences. So the Self-Building Our Lives project, we actually had 4 local advisory groups. Okay, so it was a multi-site project, and we were looking at 2 sites in Scotland and 2 in England. And we found that we really needed to tap into, the local networks of people within each of those areas. So our local advisory groups had local advocates or advocacy organizations, disabled people organizations, as well as a range of disabled people with lived experiences. So this method really helped us to think about the more inclusive methodological tools. So if you were, for example, hoping to do interviews or focus groups, we developed a range of different facilitation materials, which I'll show briefly in the next couple of slides. And it was really the participants on our advisory groups that helped us develop those. But of course, working very closely with a group who, may require more support with articulating their experiences, that more time is required. And we were also very aware of not overburdening the participants, because although we paid the advisory group members, we were aware that in some cases, they were just so busy, so advocacy workloads, for example, and really just trying to kind of help not overburden them. And we also found that this mantra of my space, your space, our space was really helpful in just trying to set boundaries with the participants on the group. So that helped really just articulate the view that, we as academics, or you might have some clinical background, that you basically need to explore or to explain what kind of expectations you have as a particular researcher. Your space, really trying to help them clarify what space they're occupying as a user, and really then coming together and thinking, well, what can we both bring to this relationship, and what can we put into our space that will really provide a meaningful form of engagement. So here is just a couple of examples. You can see here I'm really getting involved here with some of our our advisor group members, and this was a very kind of early practice that we did, where we were trying to get the members to design the logo for the project. So you can see up on the top right corner the self-build social care logo. And this was repeated in each of the 4 case study areas. We used a collaborative tablecloth, so a paper tablecloth, and got lots of paints and arts, which was a really nice way of building up our relationship with the participants. And I mentioned those types of those interview facilitation methods. So we had these circles printed out on large A3 sheets and asked people to talk about the people in their life, what a typical week looks like. And I think that's quite telling, because immediately you can see huge chunks of the person's week in the evenings and over the weekend that people didn't really have a lot of social encounter or activities to take part in. Just to kind of begin to wrap up my presentation, I'm kind of aware of time, and I'd like to provide some time if you have any questions. When I rewind back to the time of the Ibsen report in 2008, and I remember reading at that time the challenges for this national evaluation to try and get local authorities on board with random controlled trials. So that is something to be aware of, that the RCTs are more rare. I wouldn't say they're, I've got a couple of exceptions to this, but I would say it is rarer in social care research, and there can be some local reservations about the ethical and practical aspects. So Ibsen found that they really had to continue a dialogue with local authority staff, and really trying to justify and explain the acceptability of withholding support for a particular group. But for Ibsen, what helped justify that was because the group didn't have the intervention. It was more of a delayed rollout. So they were able to say, well, at the end of this trial, we will be able to roll it out to those other groups. So that's just something to be aware of. But of course, there are some exceptions. So Angela Hasiota's work, Philip Whitehead, so they've both provided some of the links there to some examples. So final thoughts. I think it's fair to say that you have to tread relatively carefully, that this is a sector that would be arguably quite fragile in terms of the funding settlement. There are a lot of overstretched people working in the sector. So, you do have to be mindful of that in terms of recruitment and, really trying to be careful about building up those relationships. One helpful way that I did that was, if I rewind back to before the Self-Building Our Lives study, when I got my position at Southampton University, I applied for a very small grant called an Impact Acceleration Account grant. So many universities have this pot of money that can be used to just do some pump priming work. And I used that to help fund and kind of co-found a disability research platform across the South Coast. So that was an opportunity to just reach out and build relationships with, with local representative groups in my area. And that really was fundamental in helping me then build a larger bid for the ESRC. Okay, and I guess those other points I've already mentioned about the legacies of institutional provision and the different lineage within the social care sector. And I would say that over the next 10 to 20 years, we're really going to see closer, more integrated health and social care. This is likely to continue to evolve. So I think as the different stakeholders have to kind of grapple with that, it is a very fruitful time for exploring how social care and the key stakeholders kind of grappling with that change.